everyone. My name is Dr. Amarquaye, and I am a clinical pharmacist currently practicing in Tampa, Florida. And to start off with this sickle cell series, we're going to be discussing management of acute chest syndrome in sickle cell patients. By the time this presentation is done, you should be able to have a good understanding of the epidemiology and pathophysiology of ACS. We're also going to discuss presentation and diagnostic criteria of ACS. And then we're going to get into the clinical management and treatment of ACS in the emergency department. So we're going to start off with a case study. LS is a 42-year-old African-American female who has a past medical history of sickle cell anemia and major depressive disorder. She presents to the emergency department with generalized pain in both her legs after failing her home pain medication regimen. The ED team started with vaso-occlusive crisis management, and the patient was eventually admitted to the floor. On day 4 of admission, LS develops fever, cough, chest pain, and respiratory distress. When a chest x-ray was done, it was revealed that the patient had pulmonary infiltrates, and after ruling out other pathologies, was diagnosed with ACS. So continuing the case, some of the medications that the patient was taking outpatient included her MS Contin, 30 milligrams BID, and then also Percocet as needed for pain. As far as the non-opioids go, she was taking sertraline 50 milligrams daily and also was taking a multivitamin daily as well. As far as her social and family history, she does live with her husband and one child. She does not smoke or use any illicit substances, but she does endorse alcohol occasionally, 1 to 2 glasses of wine every couple months. As far as surgical histories, she did have a C-section in 2018 and then also a bilateral total hip replacement in 2021. Now getting into the overview of ACS. ACS is a form of acute lung injury that involves vaso-occlusion within the pulmonary vasculature. ACS is also considered a life-threatening thoracic complication, and this can result in lung injury, difficulty breathing, and low oxygen to the rest of the body. And it's also very important to note that ACS is considered a medical emergency and needs to be treated accordingly when the patient presents to the ED. Vaso-occlusion pain is considered the leading cause of hospitalizations in patients with sickle cell disease. About 10 to 20% of these patients develop ACS within 3 days of admission. ACS is also considered the second most common cause of hospitalizations for sickle cell disease patients. And ACS also accounts for approximately 25% of deaths in patients with sickle cell disease. And it's also important to note that 80% of patients with ACS experience a vaso-occlusive crisis even prior to the episode of ACS. So it is important to note that, as I mentioned before, it is a medical emergency, as we see here, that 25% of deaths in patients with sickle cell disease are from ACS. So getting into the pathophysiology of ACS, as you see this diagram here, this kind of represents a cycle. So you see here we have lung infarction, inflammation, atelectasis leading to ventilation perfusion mismatch and hypoxemia. So due to the nature of this disease state, you have abnormal red blood cells, you have low alveolar oxygen tension, and you have adhesion that occurs to each other. Leukocytes and endothelium, which causes vaso-occlusion and tissue hypoxia. It's also important to note that inflammatory cytokines get released from this process, and that promotes inflammation of the airway. So that's kind of how we see the presentation, as we will talk about later, involved, in the pulmonary vasculature due to the inflammation and the vaso-occlusion that occurs. Now, getting into a little bit more of the pathophysiology. So the role of VCAM1, or vascular cell adhesion molecule 1, which happens to be upregulated in the endothelium from a hypoxic state or fat embolism as well. The upregulation of VCAM1 has a role in inducing red cell adhesion to the respiratory endothelium and increasing vaso-occlusion within the pulmonary vasculature as well. So as you see this picture to the right, sickle cells can clump together in the lungs, and it can cause pain and trouble breathing. So, as far as the presentation and diagnosis, the presentation and severity associated with ACS, it can differ significantly in the patients that you see in the ED. But ACS typically presents with chest pain, cough, dyspnea, fever, leukocytosis, with new pulmonary infiltrates on imaging as well. And severe ACS can also present with rapid respiratory compromise and multi organ failure. And with multi organ failure, usually it's acute dysfunction of at least two organ systems. And important to note, patients can also present with neurological symptoms such as seizures. Now, getting a little bit more into the presentation and diagnosis, I kind of wanted to highlight this landmark study by Vichinsky and colleagues. This was published in 2000, and this was a multi-center prospective study. And they examined over 600 episodes of ACS in 538 patients and studied causes and outcomes in ACS in sickle cell disease. And they actually identified a specific cause in about 38% of patients. And when the incomplete data was excluded, they identified a specific cause in 70%. So the two main etiologies were fat embolism and infection. So getting more into the causes of acute chest syndrome, as you see this chart from the landmark study, they kind of broke it down as far as the age and kind of the percentage of the exact cause. So in ACS in adults, the most common etiology we kind of see is vaso-occlusive crisis and fat embolism. And then as you see with pediatrics, the most common etiologies is usually infection and asthma as well. So another great thing about this study is that, as you see in this table, they kind of looked at the infectious pathogens that were isolated in the 671 episodes of acute chest syndrome. And we see here the most common pathogens were Mycoplasma pneumoniae, RSV, and Chlamydia pneumoniae as well. So that's why antibiotic therapy is important to use in these patients in order to provide optimal treatment. So getting a little bit into the diagnostic criteria, some of the ones listed here include acute illness with a new pulmonary infiltrate. We're also looking at one or more new respiratory symptoms or signs. This includes cough, chest pain, fever, hypoxemia, wheezing, tachypnea. It's also important to note that this criteria obviously is very broad. So for the providers, it's important to do a proper differential diagnosis. So looking at pneumonia, PE, pleural effusion, etc. And also, it's important to note that infiltrates may not appear until 2 to 3 days after initial presentation. So one should not cross out the possibility of ACS just because the chest X-ray comes back negative. So getting into a little bit of the treatment algorithms of ACS, I kind of wrote down here some of the most important aspects. So obviously that includes analgesia, antibiotic therapy, respiratory support, fluid management, and then also blood transfusion is another important factor as well. So as I mentioned before, early recognition and prompt initiation of treatment has been seen to be associated with lower mortality rates, shorter hospital stays, decreased healthcare costs, and a reduced likelihood of recurrence as well. So it's important that we make sure that whenever we see these patients in the ED, that we make sure that we're treating this as a medical emergency and making sure that we treat these patients as soon and as possible. So let's get into the treatment of ACS. So getting into the analgesia, as I mentioned before, vaso-occlusive crisis is a common trigger for ACS in patients with sickle cell disease. So you have to make sure that when a patient presents with acute pain from vaso-occlusive crisis, that you make sure that if you have certain protocols within your ED for pain management, that you use them, because we want to make sure that we treat the pain as early as possible and make sure we properly examine the patient and make sure that we're listening to the patient and understanding what exactly is wrong as far as the pain wise and doing our risk assessments. It's important that we also utilize multimodal analgesia. So this is kind of how pain is being treated nowadays, especially with multimodal analgesia. It's not really recommended to use just one agent. It's better to use multiple agents that can attack the pain pathways from different angles. So we're going to use different agents for patients who present with vaso-occlusive crisis. Also, it's important to note that we do have guideline in regards to vaso-occlusive crisis, the ASH guidelines, and it can help us out to treat pain in these patients. So getting a little bit more into the analgesia, I have listed here some of the meds that can be used for vaso-occlusive crisis. So obviously we have opioids. The ASH guidelines mention that it can be patient specific, which is usually the best way to go because you can have individualized pain care. You know what the patient needs as far as dosage wise to get their pain under control. And then also there's another option of weight-based regimens as well. So for example, if you want to use morphine, we have a weight-based regimen of zero point 0.1 to 0.15 mg per kg. And then as far as NSAIDs, we usually go to Toradol. That's usually used for 5 days. We don't want to use that for more than 5 days due to bleeding that can occur in the patient. And then also we have acetaminophen. And then also the guidelines mention if you have pain that's refractory to opioids, you can use pain dose ketamine. So as far as the dosage, we're looking at 0.1 to 0.3 mg per kg per hour, and then a max dose of usually 0.5 to 1 mg per kg per hour. So it's important to note also that NSAIDs and Tylenol, these shouldn't be used PRN when ordered in the ED. They should be scheduled. And that's another important aspect of the multimodal analgesic regimen as well for these patients. As you see in this chart, multimodal analgesia represents many different things. So we want to use all these different agents as best we can. Obviously, if there's contraindications, if patients cannot use some of these meds due to contraindications, they have CKD, or if they have any liver issues, we want to decrease the dose of acetaminophen as well. But barring any contraindications, we want to make sure that we're using these agents in our patients. So getting into the antibiotic therapy, infection is another common trigger for ACS. As I mentioned before, the landmark study kind of went through some of the most infectious, the common pathogens. And so antibiotic is very important in these patients. As we saw, atypical organisms are common infectious agents in ACS. So as far as antibiotic therapy, we can use our third generation cephalosporins such as Rocephin, and we can use that with the macrolides such as azithromycin or fluoroquinolone such as Levaquin. And depending if the patient is critically ill, we can use Zosyn and vancomycin with the macrolide as well. So it depends on how critically ill your patient is, will depend on kind of your antibiotic therapy that you choose for your patient. So getting into a little bit of the respiratory support. Respiratory support is very important in this patient population. If the patient is hypoxemic, you want to use supplemental oxygen, and it should be administered to attain an oxygen saturation of above 95%. And now this is some examples: nasal cannula. And then if the patient is unable to protect their airway, we want to obviously do mechanical ventilation as well. Incentive spirometry is another important aspect of ACS management. Recommended to do 10 maximal inspirations every 2 hours. And incentive spirometry also helps to improve tidal volumes and also atelectasis as well. So getting into the fluid management for these patients. So Wang and colleagues actually discussed the importance of making sure that our fluid management is conservative and individualized for the patients, and we have to consider their fluid status as well. It's important for conservative and selective fluid management because fluid overload has been implicated in triggering ACS by inducing atelectasis or pulmonary edema as well. So that's why it's important to make sure we have proper fluid stewardship. So if the patient is euvolemic, maintenance fluids can be started. So for example, D5 and half normal saline at a maintenance rate to avoid overhydration. If hypovolemic patients, in hypovolemic patients, fluid resuscitation should be employed as well. The ASH guidelines, it's interesting. The guideline panel actually chose not to offer a recommendation for or against IV fluids. in addition to standard pharmacological management. So, this goes to show you that we do need more high quality studies regarding efficacy and risks of IV fluid in treating ACS. And fluid management should be guided by the patient's hydration status to restore and maintain adequate hydration without causing fluid overload, as I mentioned before. So, as far as blood transfusion, we're going to be discussing this next. As I wrote here, we have either simple transfusion or exchange transfusion. So, for simple transfusion, we're looking at symptomatic ACS. We're looking at hemoglobin of less than 9, and then we're also looking at a decrease in hemoglobin greater than 1 from baseline as well. And then as far as exchange transfusion, we're looking at hypoxia despite oxygen supplementation. The patient has worsening pulmonary infiltrates and also increasing respiratory distress, and then also decreasing hemoglobin despite simple transfusion. So simple transfusion is used to help compensate for the symptomatic acute or chronic anemia in the setting of hypoxia, and also to reduce further sickling and worsening of ACS. And as far as exchange transfusion, this allows for a large volume of blood transfusion without the risk for hyperviscosity syndrome. And this also allows for improved oxygenation by removing the patient's sickle hemoglobin and replacing them with the hemoglobin A. And this results in reduced blood sickling and hemolysis as well. So as far as blood transfusion, we're looking at a target of hemoglobin greater than 10 grams per deciliter for both simple and exchange. And for adults, it's recommended 1 to 2 units of red blood cells. And then for pediatrics, 10 mLs per kilogram. So this concludes the management of acute chest syndrome in the ED. And these are my references. Thank you.